Well, hello, everybody. Good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. Welcome and thank you for joining us to today's live webinar hosted by Roji Health Intelligence. And it is called 5 Ways ACOs Can Boost Cost Control Through APP Reporting. And there's going to be a lot of good information shared today. And also the slides will be available. I know we get that question a lot, so after the fact, we'll send a recording over to you, and you'll be able to download the slides, watch the session again, share that with colleagues, and we hope that you do. We are going to have a time for some questions, some Q&A towards the end of the presentation. So if you have any questions at all for our speaker, who I'll introduce momentarily, you can go ahead and drop those into your module. There's space specifically for questions, so go ahead and put those in there at any time. You don't need to wait till the Q&A in order to do that. And we're going to get to as many as we can during the allotted time. And if we don't get to yours for some reason, that's okay. Someone will reach out to you afterwards, and you will get your question answered. So, and then finally, as I mentioned too, the session is being recorded, and we're going to send you an email afterwards, and you'll have a link to where you can, again, watch the recording at your leisure and or download the slides and share that with colleagues. So without further ado, I wanted to very briefly introduce our speaker today, Ms. Terry Hush, and she is the CEO and co-founder of Roji Health Intelligence. And welcome, Terry.
Well, thank you very much, Garrett. Excited to be here today, and we've got a lot to talk about cost control. And so let me get started. A little bit about us and why we come to talk about cost. We provide value-based care technology and services in both outcomes and services to reduce costs. One of the ways that we do that is on the data side, we're an ONC certified registry for APP reporting, and we do Roji episodes, which give you a lot of analytics and interventions to manage cost. And this presentation is for ACOs and other providers, health systems that are on that path to they're either involved in risk or you are trying to address affordability and improve your savings. And so, without further ado, first I'd like to introduce my co-presenters today, who are my dogs. And you know, in a cost thing, you have to make it a little bit light on it. And so we have, to the left, we have Tane when she was a puppy, who's a puppy bearded collie at the point. And then we have Mac, the older bearded collie, and then puppy Pippi, bearded collie, and my golden Nika. And they are my co-presenters. But what we really want to know is where you are, where your organization is in managing costs right now, because that helps me kind of gauge my comments towards the right direction. And your choices are, you may be a little puppy trying to go at things the very hard way, which is manage to chew a stick while it's still growing in the ground. And if that is the case, then you should respond with A, that you are using claims data to address high utilization and expenditures. Or you may be more advanced in your data at this point and you're using B, EHR data to address patient outcomes as a way of controlling costs. Or maybe you don't know which way you're going, and so you are the fluffy beardies in the wind and spinning around, and then you would answer C. Or maybe you just don't think my dogs are appropriate. They may be too hairy for your taste, and you need more options, in which case you would choose D.
All right, so we pulled this poll up on the screen now, and you'll just select one of these, and we'll wait till the responses come in. And then we'll actually show the results as well. So, and of course it's anonymous, but you'll be able to at least kind of see where you stack among with your colleagues. And so we'll give it a few more seconds here. and then we'll share the results. So I think most of the responses have come in. So I'll close it down in about 5 long seconds. 5, 4, 3, 2, and 1. And I'm going to share the results here. Okay. Terry, are you able to see the results or you want me to read those
No,
out?
I'm not.
Okay.
So maybe
So
you
we've
could.
got, yeah, sure, no problem. So the very first one, address high utilization and expenditures using claims data. We have 56%.
Okay.
Yeah. Next one, prevent avoidable costs by using EHR data, is 13%.
Okay.
Not sure which way to turn yet, is 25%. And
Okay.
then I need more options. These dogs are too hairy, is 6%.
Well, unfortunately, you get to see a lot of these hairy dogs going forward because they're populating some levity in the material. But thank you very much for your responses, and let's move on. This is a very busy slide of all the things we're going to cover, and its purpose is to tell you really that we're going to talk about what total cost of care and total per capita cost are, how we're going to go about it through APP reporting, some of the 5 promising areas that you can use, how you would do it, and how you can clear your path to cost control. The sub-theme of this is use the tail to wag the dog. So what do I really mean? APP reporting is loved by nobody, I think. It is a regulatory program, or it's perceived as a regulatory program and not quite a quality program. And my thought is, why not use that tush to wag the the data on costs? It is quality data. It may not be the be all end all in quality data, but it provides a sound foundation for starting initiatives that do something a lot bigger, and that is control the costs. So a little bit of definition, and I'm going to abbreviate this. The total cost of care is simply everything that you are charging for, or your allowed costs that are being considered by your payers and paid by your patients. It includes physician and hospital and behavioral health and prescription drugs and ancillary services. Total per capita cost is simply total cost of care divided by your number of your patients. And it's a way that you can more easily compare total per capita cost from one facility or one organization to another. The actual definition of total cost of care is somewhat flexible because it can also be defined by a particular value-based payment model. Drugs can be in or out, SNF can be in or out, ancillary services can be in or out. And in some cases, we're talking about everything except physician services being out to replicate a physician-based capitation payment. But the point is to aggregate all of your costs and take a look at what's really driving the total cost of your patient care. More important, this is how payers and patients are measuring your affordability. So when patients say, I can't afford to go to X, or I can't afford that provider, or it's giving me better results on Amazon or Medicare Advantage, for example, using a payment model, this is what they're talking about. They're talking about how they perceive your affordability. But providers have a problem. The issue that we have right now in the Medicare program is that even though there are significant savings in terms of millions and tens of millions of dollars, the overall aggregate savings as a component of the full Medicare program is minimal. And so it presents an economically and politically unsustainable future for Medicare as it exists right now. And we are seeing that already come out in campaign discussions. And we'll continue to see that until we find a way of addressing the total cost of care. The other issue that providers have is that if you're a higher cost provider, as measured by payers, because remember, this particular metric is measured by the people who are paying you, not you. They manage your flow of patients. And so you're cut out of networks, or you're put in more expensive tiers, or you're simply cut out of their entire program, which may or may not be a problem for you depending on who the payer is and where you are in the country. Competition and greater risk models are becoming the norm. So you see corporate healthcare, which really loves risk models, participating in competitive vehicles to you. And what are they after? They're after your patients and your physicians. So moving to value-based reimbursement is happening across the healthcare. There's really no avoiding it. TPCC is the target of value-based payment models with risk, like ACO REACH. Medicare Advantage payment models are increasingly moving to, again, back to capitation. And then the new specialty care models like enhancing oncology are population-based payments. But here's the problem you also have. Since the payers are doing measurement, and that includes CMS, you are often lacking the detail to challenge or replicate those cost calculations. So you're sitting in the dark trying to figure out how you can really manage the payer's expectations of your affordability. What this really leads to is that providers lack the perspective and tools to self-measure their costs. They don't really know how to do it, how to start it, and that's the more important problem that we have going forward. And thus, the reason why we need some tool like the APP to get us on a track of cost control. Because not playing is not a great option. It's just no fun. And in the end, it's self-defeating. This is Mac. Value-based payment is always going to be a balancing act between the expenditures, which are services provided to patients, and the health status of those outcomes. So this is the connection between cost and quality that we can use from the APP. This is Pippi managing the dog walk. So let's take a look at the three measures in APP reporting and check it out to see whether we can use these outcome data. Active reporting is required for three measures. There's diabetes, hemoglobin A1C. There's screening for for depression, and controlling high blood pressure. So three measures, all with outcome data, all required to report on some number of patients, either Medicare only or all patients. APP is also the basis for measuring equity. So one of the advantages of using it for any initiative is that, especially in quality, it can help also improve health equity. The reason that APP data opens your options for cost control is that each method of APP reporting uses patient outcome data. And some of those reporting methods will generate richer data than others for cost initiatives, but all of them will allow you to go through the obstacles that you have to help improve outcomes and reduce costs in that way. But let's take a look at how the three methods of APP reporting differ in the overall level of data that you can use for cost initiatives. And first, I'm going to talk about ECQM. This is an AI-generated image under the prompt of a funnel-shaped tunnel with a dog running out of it. So they missed the dog part, but we got the rest of it. So on the smaller end of the data spectrum are the QRDA ones. Very large files, very small amount of content for each data. It's basically the data and one measure or whatever measures the EHR is collecting. Every QRDA is different and defined by the EHR. But in each case, you're going to get the value of the measure for the patients who are eligible for the measure. And you may not get any other data at all. If you have a hemoglobin A1C, a patient with diabetes only, you may get a measure with hemoglobin A1C. You won't see the patient's values for their lipids. You won't see BMI. You won't see any other values besides the QRDA value for that measure. Now, some EHRs will give you a smattering of measures. It's not predictable what you'll get. You might get a smoking measure. You might get something else. It's how the EHR defines it, but in any case, it's very limited compared to the other methods. So if you are using a CQM method, any data is open to be aggregated and put into the database along with the patient eligibility. So you can use flat files, you can use QRDAs, you can use any numerator data for the measure that comes derived from the technology that the provider has. Your only limitation between Medicare CQMs and all patient CQMs is the limit on the population itself, with all patients obviously being much larger. So looking at that same data content in a tabular format, QRDA1 will report on all patients in the group, but very limited value to the actual data file. Medicare CQMs report on a smaller number of patients in the ACO, but it could potentially include just about everything, as it does when we aggregate data. No matter how we aggregate it from our client organizations, we are collecting all clinical data and all across the entire year. And then, of course, the all patient is the same kind of data, but you don't have a limit on the number of patients. But even APP reporting that's on the smallest end of the volume or content scale creates some beginning. So the three measures together can identify cohorts of patients with heightened risk or trigger evaluation. If you've got both hypertension and diabetes, and you've got depression, that's a bigger issue than if you just have one or the other. You can also identify, because diabetes and hypertension often go together, you can identify patients who should be screened for hypertension or should be screened for diabetes when they have one of the conditions. In combination with claims data, you can integrate that data and find patients needing immediate visit. Maybe they're not showing up on a QRDA because they weren't eligible and the EHR doesn't report patients that are not eligible. Well, if you've got a diagnosis through the claims or you've got hospital events through the claims, then that's a mechanism for you to find those patients. So again, the point with cost is to use the data to create an intervention that is going to affect use the quality data to find an intervention for cost. So where do you begin? This is the puppy Beardy, a little older than chomping at the stick, and very hard to find where the tail and the end is of this one. So here are 5 areas that I think are worth considering for cost initiatives with APP. One is patients with poor control and diabetes and hypertension. If you're using only claims data, this will be the first data you may see with the actual clinical values that can help you see those patients over time. Behavioral health. Patients at risk of metabolic disease, so we're talking about more of a patient risk assessment you could consider as a cost initiative. Early kidney disease identification and specialty care services. So let's take them one by one. So what's in the data on diabetes and hypertension? Well, the APP measures provide the actual blood pressure values and hemoglobin A1C. QRDA1s or flat files give you many values over time. So if you're collecting that data over the year and submitting it to your um, reporting vendor, they are going to see many values and they will be able to trend that value over the year. You can see whether the patient is improving or whether the patient is worsening. You can see the patients with the most problematic values. And then in combination with your claims data and other potential EHR data, you can show comorbidities that can increase risk. So the point is you've identified a core population that you can act interventions on. That measure data is your path to taking action. So here's Pippi. You can see she's coming out of the tunnel with clear direction. This is what the integration of claims and EHR data actually give you. You can identify patients for review or change in their treatment program. If you're seeing a stable line of really extreme poor values in diabetes and hypertension with no change throughout the year, then it's time for a clinical review of those patients, and they can be queued up in population health to be pulled in for visits. You can review patients for SDOH. Same thing. If you see a clear line there, if you've got EHR data, you can also get medication data. You can see whether no change in medication has occurred for those patients, or maybe the patient is simply on insulin and they're unable to afford more. So bringing them in for an SDOH screening would be an important thing to do. You can initiate self-management programs or case management programs. You can do self-monitoring or patient monitors, glucose monitors, and patient reporting, all built on those pieces of data, which give you the first handle that you may be seeing until they get to the hospital and show up in claims who your impending risk is. Behavioral health. So what's in the data there? Well, there's patients with any indication of depression by failing the screen, with or without a plan going forward. Obviously, if they don't have a plan going forward, it's something that needs to be addressed. And you can also find patients with depression and diabetes or hypertension, in which case then you may want to have initiatives developed specifically for that group. Again, measure path is your path to action, measure data. And with this, you can integrate claims and EHR data. You can identify patients without treatment plan, and with hospital and ER visits. So that gives you a definite beginning spot to engage in a referral process or to community resources or to virtual resources for their treatment. So looking at patient risk for CVD and for stroke, what's in the data? Again, well, for patients with metabolic disease markers, A1C, hypertension, obesity, hyperglycemia, dyslipidemia. I mean, if you are collecting a more data method, CQMs, if you're embarking on either Medicare CQMs or you are looking at APP with all patient data aggregation, you will have all of these values in the data to enable you to start to work on interventions. And of course, you'll have the hospital data and ER events and other diagnoses such as AFib. This kind of data, as rich as it is, if you're looking at really CQM data with a lot of clinical information as well as claims, gives you the ability to start working on patient risk assessment methods by identifying patients with multiple indicators and utilization events, investigating unknown diagnoses like missing hypertension or missing values that should be in the mix for certain conditions, or for medications that are they're addressing the diagnosis, but the hypertension or the diagnosis is missing, can increase your HCC score as well. Patients moving into diabetes without a glycemic indicator, but not yet an A1C, gives you your early diabetes population to work on interventions and also put in your risk assessment model. Using values to enhance data-driven risk assessment is one of the most important things that you can do to start data-driven strategies for interventions. It also is a mechanism for you to inch your way into the world of AI, which is all about data-driven risk assessment or AI-driven risk assessment. And chronic kidney disease is one of those areas where there are already algorithms, AI defined, that can provide a mechanism to identify chronic kidney disease based on these indicators. Risk factors such as hypertension, diabetes, cardiovascular disease, obesity, age, and then, of course, the lab values. You would not be collecting these lab values if you are using a QRDA method and are simply doing ECQMs. But if you are doing CQMs, these would appear in a data pool that we would typically do, and I imagine possibly some other vendors too, if they're approaching costs through quality like we are. If your data aggregation is not limited to QRDA1s, you would want to be collecting this data in order to identify early kidney disease. In this case, full data aggregation of clinical data would be your path, either for Medicare CQM population or all patients. And you would be following an algorithm from the Society of Nephrologists, their protocol, by taking the CQM data and processing it on with the blood serum level and identify those patients with chronic kidney disease. And then you could proceed to Population Health Initiative to screen those patients with suspected CKD and develop lifestyle and other modification programs. Well worth the effort. And the final area that I want to cover is specialty care costs. So what's in the data there? Well, you've got specialty providers, diagnoses, whether or not they are in your data on the EHR side, you are going to find them in claims. And procedures and diagnoses from patients referred to and independently sought specialists are going to be very important for you to be able to control the 40 to 60% of your total cost of care that accounts for specialty care. The question is, how can you improve your understanding and collaboration with specialists if you're not really looking at this measure data to be able to do it? And how can you assist in the management of patients under specialty care through your primaries? Data sharing and collaboration is a path to action here. CMS has requested feedback on ACOs encouraging the use of MIPS value pathway measures for specialists. That is data that specialists may be very willing for a referral arrangement to share. Sharing costs, sharing collaboration on episodes related to cost variation is an extremely important and strong interest among specialists in looking at their cost variation, but it is hard to do without having all of the data clinically and claims-wise aggregated. Then you can build referral arrangements built on those shared activities to address the costs and create protocols for referrals and communications for your primaries. The thing here is that data is your power. And so your goal for quality reporting should also be to build the data for your reducing total cost of care. The peak performance for ACOs is about value. So the data you're collecting for the APP reporting needs to also do some double duty here. It needs to do work. You don't want to have a one-off expensive process to collect APP reporting data and not use it for total cost of care. So if your APP reporting method requires more data, it just increases your opportunities for total cost of care reduction. But balancing that for you is going to be a, um, it should be a doable process. The only difference is that your total cost of care is going to give you a dollar return. Whatever you spend on aggregating your data for APP reporting does not give you a dollar return. It simply gets you to the gate for savings. Now it's time to work on the savings. So do you have a path to that data? Uh, do your ACO practices understand the value of data-driven initiatives? Because if they don't, your path to getting data from their systems is not easy. Can you influence the gravitation of practices to a centralized system or to a certified status as the rule requires, or not? It will be easier and cheaper if you can provide a centralized system, but that isn't in everybody's possibility. But it is in everyone's possibility to help physician practices aggregate on a smaller number of systems so that it's easier and cheaper for you to get the data that you need to do your job. Do you have a vendor with experience in practice data aggregation across many systems, patient matching, integration with claims data? It's a must if you're going to be using data for anything else besides APP reporting. And for that, even for APP reporting, you will need a vendor with these capabilities. So if you have the data, then what? Well, your next step is going to be breaking that down into measurable units, and the measurable method is episode of care analytics. By using episodes of care, you can compare the total cost of care for one patient, which is an episode, against another patient, and mapping the cost variation and quality variations patient to patient. That's the way you identify your target population for interventions, by identifying patients who are failing to improve regardless of what's going on with them, seeing the same values, as I mentioned, straight line of really poor control measures over time. The episodes, though, to do that have to be very clinically focused. You can't have a bundled payment episode, even in procedures, because they're not really clinical. They're consisting of various diagnoses. And so the episode becomes a matter of what costs more, this diagnosis or that procedure, in the same bucket doesn't make any sense. So you have to have something that is enough to enable physicians to trust the data and look at the cost variation and actually understand what they may be doing to increase or decrease that cost. Within each episode, you can compare what services and costs vary. Episodes can reveal the cost drivers. You can easily see them in the data once you look at individual patient stories. It can be something like a poor patient choice for a procedure that can drive the cost up. Or it can be, you can see all the patients in diabetes who are failing to improve all happen to have heavy obesity. So what is your intervention? Is your intervention going to simply slam on the hemoglobin A1C, or are you going to address obesity is a mechanism through medications. So, three takeaways I want to leave you with before we get to the questions. To ensure that your ACO and APP are reporting, you should also maximize your opportunity for cost control. Consider the value of your data. Data is your most expensive resource to retrieve and the most valuable to all of your ACO initiatives, no matter what they are. Medicare CQMs are a really good middle ground that can provide potentially more data value depending on how you're aggregating the numerator values of those measures. You can do a hybrid. You can aggregate from some systems that are easy to aggregate from and use portal entries into your registry vendor's system to be able to address other values, but it still gives you the basic clinical data you need to pursue costs. And now I'll take any questions.
Okay. Well, thank you, Terry. This was it's very informative. Obviously, there's a lot here. There's a lot of information, and don't worry, we're going to make this available for you. We're going to email you afterwards with a link to the session and to the slides, so you'll be able to see all that. But we do have some audience questions. If you do have a question, go ahead and drop it right now into your module there. There's a place specifically for questions, and in no particular order. Here we go. We'll start with this one. Since claim data has HCC risk scores in all patient services, why can't you just use claims data to manage total costs of care? And why do you need to add data from provider if it's already in claims?
HCC data, it's a really good question. And I think people are very confused about HCCs and their capacity. HCCs are a risk score that is not a predictive risk score. It's a retrospective based on number of diagnoses and how good your coding is.
Hmm.
So it doesn't really give you the population that is on the cusp of doing worse or is really doing worse already. It simply tells you how many people have complex diseases. Those patients may not ever show up in an ER or in in an inpatient venue. The only way you can actually predict and advance your interventions is to deal with the patient's issues at hand, and that's there in the clinical data.
Great. Okay, next question is if you need claims data for controlling cost data, what advice do you have for ACO contracts with commercial health plans? None of them will provide claims data.
That is a very good question. You have to argue hard and long, and sometimes you will get part of it. I think also one of the things to do is to, I mean, I managed a very, very large group as an employer, and I was able to get claims data from Blue Cross years ago. I think it matters who you are and how you can organize. Various coalitions of employers can be very helpful. Working with employers can be helpful in getting their claims data. Some of them are self-managed and get that data. I think you have to turn all of them. If you're exploring ACO contracts with payers and they're not willing to give you claims data, see what you can get. If it's not patient specific, it isn't going to be very helpful, but it would be more helpful to get any data than no data. It's all about what you can do is all determined by the data.
Yeah, and I would say from my own past life in consulting work that I can't emphasize enough the relationship that you build with the contact at the payer, and how
Yes.
important that is to manage that. Don't underestimate that, because they'll want to help you out, and if you have a good relationship with them. Next
Yes.
question is, what is different about the data you get under the three methods of APP reporting that changes the data available for cost analytics?
It's the format in which the data comes. So QRDAs have a particular format, and they're designed to through an EHR, and the EHR's programs make it possible to retrieve that data from the file, put it, and then collectively add all the QRDA ones and report to Medicare. If you were in the MIPS program, for example, that's what they do, and report quality to Medicare. There's So therefore it's very abbreviated. Not abbreviated in format. It's more expensive to process QRDA1 files than it is to take flat files and organize all the data in them. But that's what the difference is. Having data that is formatted, very strongly formatted, sometimes reduces the amount of data that you actually are getting when you ask for it. When you create an interface, like the interfaces that used to be created all the time from EHRs to organizations like us, data aggregators, we would open up this very expensive interface, and there would be no data in it. It's just like, oh, well, the practice didn't want us to open that field for reporting. So it's what the design was. QRDA ones were designed for a method of interoperability to take the lowest amount of data and make it satisfy a measure.
Okay, great. Next question is this. Are there any other sources or resources you recommend for information and education regarding APP quality reporting, rather?
Yeah, we do a lot of education ourselves. um, we do Roji tips. People should go on our website. I write blogs. Dave Halbert, who's head of the client team and our Medicare expert, goes writes blogs on the rules and APP. There's a section in our resources, so go to the rojihealthintel.com /blog or rojihealthintel.com/resources, and we publish one-page tip sheets. We've done one on what's your best path for reporting among these three reporting methods. We've done one on how you get your data together, how you help your practices. What's the first step an ACO should take in being able to organize data? And so we have a tip sheet on that. We're putting up more all the time.
Yeah, great. And if you would like to access that tip sheet or any of the others, yeah, as Terry mentioned, the Roji Health Intelligence website is they have a lot of great material, and or you can reach out to me. I'm happy to connect you with Terry as well, and get that over to you. I also, as Terry mentioned too, we do a lot of webinars with them. She does a lot of webinars, a lot of blog articles, and we also do. And actually, this would be a good transition. I think we're done with the questions for right now. But as we close out, and this is again actually good a good transition here. If you head over to vbcexhibithall.com, you'll see you can visit the Roji Health Intelligence booth. They have a virtual exhibit booth, and there's a lot of those resources here. a lot of their educational content, a link to their blog and what they're doing. You can read up on them and how they can help in a lot of different areas with your ACO or with your IPA or CIN. They've got a vast archive of tools there. And again, we're happy to connect you as well. And finally, if you wanted to connect with Terry directly or with the Roji team, um, you can do so. Terry, if I could get you to go to the very last slide, their contact information is there.
I'm,
And oh, is it
I'm,
locked up?
it won't move. I'm sorry.
Okay, well, theoretically, if you can
Uh,
imagine, their information is there. We're gonna again send you over a link to these slides and make sure that you have plenty of contact information for them and her team. Or I'm happy to facilitate an introduction again as well for you. But thank you
here we
all.
are.
Thank you all. Oh, there we go. Okay, so there's their information there on the last slide. Leonard Ho is a direct contact there who can help you uh, talk about your particular organization and maybe introduce you to some of their tools. But again, thank you all so much for joining us. Terry, thank you for a very informative session. We'll be emailing you again a link to where you can watch the session again or share it with colleagues or download the slides. But thank you all so much for spending your afternoon with us. Terry, thank you, and hope you will join us for the next session. Have a great rest of your afternoon.
Me too.
Bye bye.